This is one of my favourite topics, and I've got lots of pretty pictures for you to keep everyone awake on this early Sunday morning. So I think the true experts in the area of sarcoid are those who say they don't understand it completely. If you meet someone who says they know everything about sarcoid, the reality is that they probably don't. And that's one of the exciting reasons that I like working in this field, because I think there's still a lot of opportunity for us to really drill down on what causes sarcoidosis and the ways that we're going to be able to identify and treat it. I think suffice to say there are infectious agents, environmental factors and occupations where we know there is increased likelihood for sarcoidosis, but certainly I think there's underlying genetic reasons as to why some people manifest sarcoid and others do not, despite the same exposures. Who are at risk? Typically we see those in the middle age groups who are most populous in our clinics. And there is, importantly, to recognise an increased uptick in the African American population, particularly in female patients. And I think, sadly, many folks go undiagnosed until much later in the disease process, and we would like to make sure that that doesn't occur. When we think about sarcoidosis, it's a multi-system disease. I think we're most familiar with the highest prevalence being in the lungs, but as you can see, it can really occur anywhere, including within the heart. I might just get the gentleman in the tech to set the timer so I know how long I've got to go. How do we treat sarcoidosis? Typically, first line, steroids still remain our go-to. Second line, drugs like methotrexate is what we pull from most at the clinic, although depending on the side effects and the patient tolerance, we may pull from these other groups. Third line being biologicals. In our clinic, we work very closely with our pulmonologists. We work as part of a multidisciplinary team, and typically we'll both see the patients, albeit in our clinics separately, and then meet together for a tumour board style meeting, and we'll talk through what the drugs are that are going to be used in that patient, and then the pulmonologists will be the ones to prescribe them. That's been deliberate from our perspective so we don't have too many cooks in the kitchen, and also so that those folks who are already prescribing these drugs for pulmonary sarcoid have the logistical setups in their clinic and are also most aware of the side effects. It's important to know that really doses of prednisone above 30 or 40 milligrams per day have not been shown to be of any incremental benefit, and the side effect profile significantly increases. We all know about osteoporosis, cataracts, stomach ulcers. I think to underscore the mood disturbance, sleep disturbance, we've seen a few patients who are floridly psychotic on steroids. This is not something that we want for our patients, and these patients are often on drugs for many years. So our practice is to typically start with steroids at one of these doses, follow up quickly with one of the other disease-modifying drugs so that we can ultimately get them off the steroids as soon as we safely can. My talk is going to focus on cardiac sarcoid. I think sometimes it feels like we're in an epidemic or a pandemic of sarcoid, the number of patients that seem to be coming out of the woodwork. It's hard to know whether this is truly increasing prevalence. I suspect that we're just getting more aware of this, and our imaging tools are getting much more sensitive at detecting it. One of the things that I always say to our cardiac sarcoid patients is that the reality in autopsy studies is about 25 to 30% of patients with pulmonary sarcoid will have microscopic evidence of cardiac involvement. The reassuring factor, though, is only around 5% of those people will actually have clinically relevant disease. And so I think I see a lot of worried people with pulmonary sarcoid who want to be screened for cardiac sarcoid. And I'm not opposed to that, that's fine, but we don't want to create excessive anxiety around this. For those who do manifest cardiac sarcoid, typically the most common presentations are AV block, ventricular arrhythmias, and heart failure. And there are multiple different criteria for grading the likelihood of sarcoidosis. WASOG is the one that we use the most often. It divides things into highly probable, least probable, possible, and no consensus. I think when you have multiple different criteria, suffice to say there is no one good criteria, and that's why we're still needing to learn about this and figuring out how we can be more definitive for these patients. The yield for endomyocardial biopsy and cardiac sarcoidosis is low. It's typically a patchy distribution. You may be falsely reassured by doing a biopsy and getting a negative result and feel that the patient does not have sarcoidosis when in fact they do. This can be increased, the yield, with some electroanatomic mapping techniques, But I think for us in our clinic, one of the benefits of working closely with the pulmonologists is we often think about endobronchial-guided ultrasound, ultrasound-guided biopsy for these patients. If we do find sarcoid involvement in mediastinal lymph nodes, then our likelihood for having it in the heart increases, and we typically put patients in the highly probable bucket and treat them accordingly. We know that time is muscle, so early initiation of corticosteroids protects myocardium, and you can see here that those who present with a low ejection fraction at the beginning and a delayed start date on their corticosteroids typically do not have an improvement in their ejection fraction. So time is muscle, create awareness, let's get these folks to the right place. The other thing that we were able to demonstrate is that scar-based imaging is important, and that folks who have LGE on CMR or scar on PET imaging have reduced survival. So again, we want to treat this disease while it's in the inflammatory phase before scar forms. And also thinking about ejection fraction. Typically we place devices in patients with EFs less than 35%. Our work with Erica Hutt, one of our fellows, was able to show that those with EFs less than 42% are at higher risk for death. And so it's really important when we think about these patients that we do have a thoughtful discussion around protection from sudden cardiac death in the setting of an inflammatory process. Some of this goes slightly outside of what you'll find in any guidelines, and therefore our multidisciplinary team approach is really important so that we can talk through these patients and make sure that we're not leaving them at risk and keeping them in safe hands. I'm an imager. I'm not going to dwell on this, but I really want to show you some pretty pictures. Echo is always our mainstay. We're looking for areas of regional wall thinning, hypokinesis, aneurysmal deformation in a non-coronary distribution, although our sensitivity is low and we need additional tools to be more sure. Strain has been helpful in this scenario. Emma Joyce, who was a cardiologist from Ireland at the clinic for a while, was able to demonstrate that if your strain is less negative than minus 17.3, that is a marker in patients with pulmonary sarcoidosis that they may have underlying cardiac sarcoid. And that strain imaging does correlate nicely with the distribution of delayed gadolinium enhancement. And so as we think about layering on additional tools, start with your echo and then add in MRI to be more certain about whether or not this could be probable or highly probable cardiac sarcoidosis. I've circled here for you the areas where we typically see the aneurysmal deformation and scar on MRI. I think suffice to say, though, all bets are off in sarcoidosis. It's one of life's great masqueraders, and you can have sarcoid anywhere, as Ben showed yesterday, with distribution in the right ventricle predominantly. We can see it in PAP muscles, we can see it at the apex. I think keep it on your radar. We just don't want to miss these patients. When I report MRIs, I try and be descriptive, and I think about, is this transmural distribution, subepicardial, subendocardial, mid-myocardial of delayed enhancement? Is it focal, multifocal, or extensive? And then we overlay our delayed gadolinium enhancement, which could be either scar or inflammation, with our T2 stir edema-weighted sequence to see, is this more of an inflammatory process? I think suffice to say that the T2 stir is probably not always as sensitive as we would like it to be, and that's where we need to think about PET imaging as well, and I'll go into that. Just to highlight how much incremental benefit we have for the diagnosis of sarcoidosis with the use of cardiac MRI. You can see here the area under the curve kind of almost off the chart here in the yellow. So really think about MRI for these patients. Survival is also proportional to the presence or absence of delayed enhancement, important to remember. Most devices these days are MRI safe. But as you can see here, even if they're safe doesn't mean we don't get a lot of artifact. So if you have the opportunity to do your MRI before the device gets put in and that's felt to be safe from a patient arrhythmia standpoint, do your baseline MRI before that device goes in. Your imagers and your team will thank you. A few pretty pictures here. EF is normal. You can see here reduced strain in the basal septum, basal lateral wall corresponding to delayed enhancement on the MRI. So that one could easily be missed. Here, slightly lower EF, hypokinesis in the basal to mid-lateral wall again, reduced strain, hypokinesis on the MRI cine, and then wall thinning, delayed enhancement again. These are some of my favorite examples. These bite-like aneurysms in the inferior wall, very different from an ischemic aneurysm that you might see with the corresponding reduced strain. You can see a little aneurysm in the anterior wall here, which we missed on the echo, and then the corresponding delayed enhancement there. These are like my all-time favorite examples here for you. Really focal aneurysm in the mid-septum, very different from an ischemic aneurysm with the corresponding strain, corresponding MRI cines, and delayed enhancement. So you can see from an imaging perspective, these are pretty cool studies to read. Now, as I alluded to, we use PET to try and really help us with our diagnosis and also to determine, is this active inflammatory disease or burned out scar? We grade sarcoid as unlikely if there's no perfusion defect or FDG uptake, possible if you've got a perfusion defect, but not necessarily any FDG uptake to signal inflammation. Probable if you've got multiple non-contiguous perfusion areas without FDG uptake, so possibly scar from more remote sarcoid, or highly probable if you've got this mismatch pattern where you've got areas, non-contiguous perfusion defects with associated FDG uptake. So I think these are very descriptive terms. To show you an image here on the polar maps, you can see in the blue reduced perfusion here, and then in the same areas in the orange, increased FDG uptake, along with, for all our cardiac sarcoid protocols, we throw in a whole body PET, sort of like throwing in the steak knives when you're on your online shopping. We're giving the tracer, so why not do a whole body PET as well? This helps us. If we see all these lymph nodes lighting up, it increases our likelihood for suspecting sarcoid and gives us a target for biopsy. When you think about PET, make sure these patients are well prepared. They have to be on a zero carbohydrate, high-fat diet for at least 24, ideally 48 hours beforehand. Think about the list. It's everything that I like to eat. It's carbohydrates, it's alcohol, it's candies. Just, remember all those things that I'm trying not to eat, but it's an easy list to remember. Peanut butter, everything you can imagine. These patients, it's the only time as a cardiologist you'll say to them, go to McDonald's, buy some burgers, throw out the buns, you're going to eat the cheese and the meat, and for 1 or 2 days we want a high-fat diet. That increases our yield. Here we have an example of a patient who was called positive. We felt it was likely a false positive because there was diffuse uptake, was repeated, and there was zero inflammation, so very important. I'll just finish quickly with this case. You can see here reduced ejection fraction, delayed enhancement on MRI, inflammation on the PET. We talked about him. We thought about treating him empirically. We didn't have tissue. We went ahead and did that. Here you can see his ejection fraction improved. His first-degree AV block went away. However, this guy in his family history had lost his father at a young age from sudden cardiac death. He initially didn't tell us this, but subsequently disclosed it. For all of our patients who we're suspecting isolated cardiac sarcoid, we now send for medical genetics testing to exclude that they have another inflammatory cardiomyopathy that's getting mixed in with the diagnosis of sarcoidosis. Sure enough, this guy had a LAMIN-A mutation. And this is important because we don't necessarily know the implications of anti-inflammatory therapy for these people, and there are other restrictions such as exercise that they had to adhere to. And for him, it has implications for his other family members. So our protocol has now changed. If we're going to make a diagnosis of isolated sarcoidosis in those patients, we send them for medical genetics testing as well. So take-home messages, this is a fun team sport. Know your team, the role that everyone plays. We don't have a reliable gold standard for diagnosis, so we all have to pitch in together to increase our likelihood for diagnosis in these patients. Tissue is king, so if you can get an extra cardiac biopsy, go for it to increase your certainty. As I really hope I underscored, think about medical genetics consults before you make a diagnosis of isolated cardiac sarcoidosis. And I'm pleased to say, although we have no guidelines, we're about to publish an international consensus Delphi study for cardiac sarcoidosis, which you'll see in JACC imaging later this year, and hopefully that will give you a nice summary and some guide at least on how we manage these challenging patients. Thank you.